Uh, I'm delighted to introduce Dr. Vikram Christian, who's an assistant professor of pediatrics. He came to us from the University of Wisconsin, where he did his fellowship. He has a special focus on nutrition and was a clinical nutrition fellow at the Nestle Nutrition Institute. We were all delighted when he joined our group, and we've been happy to have him as a colleague. Today, he's going to talk about diet therapy for gastrointestinal disease, what works and what doesn't. Go ahead, Vikram.
Thank you, Sarah Jane. All right, so today we are going to be reviewing diet therapy for gastrointestinal disease and looking at what works and just looking at the latest evidence that we have for these. So these are my disclosures. I have no relevant financial or other disclosures. Our objectives are to review the evidence behind these therapies, as well as to understand the nutritional inadequacies that may accompany these diets, so we can appropriately counsel our patients and families. So we're going to be dividing this into just a few subheadings or subtopics. We're going to be reviewing diet therapy and inflammatory bowel disease, elimination diets and eosinophilic esophagitis, the gluten-free diet for treatment of celiac disease and non-celiac gluten sensitivity or wheat sensitivity, looking at plant-based milks in quotations, as well as looking at the low Fodmap diet for irritable bowel syndrome. So diets and IBD, let's start off with exclusive enteral nutrition. Now, some of you may be familiar with this diet. This is something that we frequently prescribe or start a patient with Crohn's disease on. It is a exclusive diet, which means that the child's entire source of nutrition is the formula. This could be a standard polymeric formula, meaning that a formula which is not necessarily hydrolyzed or elemental in nature, or it could be an elemental formula. Studies have shown that there really is no difference between either in exclusive enteral nutrition. In order to induce remission, studies have shown that a period of 6 to 8 weeks of being on this exclusive source of nutrition seems to be effective. And earlier studies suggested that this is applicable for more small bowel Crohn's disease, but now newer studies have disputed that. And it might also be used for colonic Crohn's disease as well. This is a study which showed the mechanism of exclusive enteral nutrition. And in Crohn's disease, we know that apart from genetic factors, there seems to be a complex interplay between gut dysbiosis, intestinal permeability, immune reaction that is driven by bacterial invasion of the mucosa and submucosa. In exclusive enteral nutrition, this exposure of the mucosa to a consistent protein is thought to decrease microbial diversity and dysbiosis, restore epithelial barrier function, which in turn prevents bacterial invasion and decreases the pro-inflammatory cytokines. This is a pediatric systematic review comparing exclusive enteral nutrition and corticosteroids for induction of remission. This forest plot that we see on the right side here shows an intersection of the midline, suggesting that corticosteroids and exclusive enteral nutrition are equivalent in inducing remission. This was seen in both newly diagnosed as well as relapsed Crohn's disease. The study also found that intestinal healing was significantly more likely to occur in the exclusive enteral nutrition group compared to corticosteroid group, and there was no difference in the frequency of biomarker normalization. This study led to guidelines being changed or recommendations being changed. And the European Crohn's and Colitis Organization, as well as ESPGHAN, which is the European Pediatric GI Society, now recommends either exclusive enteral nutrition or corticosteroids for induction of remission in mild to moderate Crohn's disease, where certain high-risk factors are not present. And these factors are extensive disease, deep colonic ulceration, or stricturing disease, in which case an immunomodulator or an anti-TNF is thought to be preferred. All right, now, the studies that I saw, I wasn't able to find anything which looked at the nutritional adequacy of exclusive enteral nutrition in pediatrics specifically, but it's likely nutritionally adequate because now the child gets all of their nutrition from formula. There's limited data as maintenance therapy. It's used primarily to induce remission. Frequently, there is a lot of hope that the child starts off with or the family starts off on this diet with, and they feel that the child is able to consume all of the required formula, but frequently we see that that's not possible, and usually some form of a feeding tube is required to get all of that formula in. And finally, this diet is difficult to sustain. So the child is not able to eat normal meals and gets all of their nutrition from that formula. And this leads us to the next diet, which is a blended diet. So it combines some whole food components as well as some enteral nutrition or formula components. And that's called a CDED plus PEN diet. And this is, again, primarily because EEN is difficult to sustain. That's why this diet was formed and has become more popular. And this diet is done in 2 stages. In stage 1, 50% of the child's caloric intake is from restrictive whole foods, and 50% is from partial enteral nutrition. And in stage 2, there's 75% of the nutrition is obtained from a whole food diet and 25% from formula. And this restriction is supposed to reduce exposure to components that have an adverse effect on the microbiome and intestinal barrier. And these are the foods that we are typically asking a patient to avoid on this diet, and that is gluten, dairy products, animal fats, processed meats, emulsifiers, which is in a lot of the foods that we eat, maltodextrin, canned foods, and packaged foods. This was a study in gastroenterology in 2019. It was a pediatric study. It was a 12-week prospective trial. Children with mild to moderate Crohn's disease were recruited and were randomly assigned in 2 groups. The first group was the classical CDED plus PEN, which is the whole food diet plus 50% of PEN for 6 weeks, and then 75% of the whole foods plus 25% of PEN for 6 weeks. And the second group was the exclusive enteral nutrition for 6 weeks. So the first type of diet that we spoke about. And after those 6 weeks, their diet was liberalized so that they were having a regular diet for 75% of their calories and 25% was based on formula. These children were evaluated at baseline weeks 3, 6, and 12. The primary endpoint was dietary tolerance, and the secondary endpoints were intention to treat remission at week 6 with a pediatric Crohn's disease activity index score of less than 10, and corticosteroid-free intention to treat sustained remission at week 12. So on the top half of the screen, you will see the significant decrease in PCDAI scores and CRP at 6 weeks of assessment. And at the bottom left corner, we see the higher percentage of remission defined by the PCDAI scores and CRP, which is higher in the CDED group when compared to the EEN group. The authors also found that at week 6, 75% of the 40 children given the CDED and PEN were in corticosteroid-free remission when compared to the 59% of children given just EEN. And at week 12, it was sustained remission. That's 75% of children with CDED plus PEN were in corticosteroid-free remission when compared to a number of just 45% of EEN plus PEN. So this study over here shows the change in the median stool calprotectin. Calprotectin is a component of the neutrophil cytosol, and so can go up in case of neutrophilic inflammation. It is also produced by monocytes, and we frequently use calprotectin as a biomarker to screen and track IBD. And this study showed that there is a sustained decrease in the stool calprotectin levels at week 12, which is more sustained in the CDED-PEN group compared to just the EEN group. Now coming to our next diet, which is the specific carbohydrate diet. So this was first introduced by pediatrician Dr. Haas in the 1920s, actually as a way to treat celiac disease. And there was this book which came out about it, Breaking the Vicious Cycle by Elaine Gottschall, whose daughter was actually treated for ulcerative colitis on the specific carbohydrate diet. This diet, the summary of this diet is that there are no grains allowed. Nut flours such as almond or coconut flours are used to make breads and baked products. The added sugar is only limited to honey and no other sugars can be used. No dairy products are allowed except for fully fermented yogurt. And it is hypothesized that the diet changes the fecal microbiome from a pro-inflammatory to a non-inflammatory state. This is a summary of the foods which are allowed and not allowed on this diet. Of note, wild-caught fish and simple sugars are allowed, and the foods that are not allowed are the canned or processed meats, all canned fruits, vegetables, condiments, starchy vegetables, and most dairy in addition to all grains. Most of the data around the specific carbohydrate origin is from Seattle. It seems like they've been doing this for some time, and they actually published a retrospective study looking at 26 of their children, 20 with Crohn's disease and 6 with ulcerative colitis. And they found that there was a significant drop in the PCDAI scores, which is that marker to monitor Crohn's disease, as well as the PUCI scores, which is the Pediatric Ulcerative Colitis Activity Index score. This group also went on to look at the nutritional adequacy of the specific carbohydrate diet. They followed just 9 patients, only 8 completed the study, 6 gained weight, 1 had no change in weight, 1 patient lost weight. They found that in general, they met, most of them at least met their intake requirement for energy, as well as vitamins B2, B3, B5, B6, B7, B12, vitamin C, A, and E. All of the children, or at least their intakes, were less than adequate for vitamin D, as well as magnesium. And they found that there were actually significantly increased vitamin A intake in these patients as well. In summary, looking at diets for IBD, the exclusive enteral nutrition is great for induction. Well, not much data on how it works in maintenance therapy. Clinical improvement is documented, mucosal healing is documented. The specific carbohydrate diet, not much data on induction, but it's great for maintenance. Clinical improvement is documented, but mucosal healing requires further studies. And the Crohn's disease exclusion diet, not great for induction, at least it's not shown yet, but it's good for maintenance therapy. There's good clinical improvement, and mucosal healing has not yet been assessed. Looking at this diet in the middle, the anti-inflammatory diet, I skip over that because there's really not much of data in the pediatric side. However, there was an adult study where a certain number of patients who followed this diet were actually able to get off one of their IBD medications, but there really is not a whole lot of strong data on the pediatric side. Now, since we've spoken a lot about animal protein and fruits and vegetables and how that can be beneficial for Crohn's disease or help in controlling Crohn's disease by some of these diets, I just want to include this study as well. This is a study which followed adult patients and stratified these patients based on how much red meat they were consuming. So either a high red meat group or a low red meat group. And it was interesting that the adherence among the high red meat group was actually close to 100%, but the adherence in the low red meat group was actually on the lower end. But the study showed that there was no significant difference in the time to any or moderate to severe relapse. And the authors concluded that patients with Crohn's disease in remission, the level of the red and processed meat consumption was not associated with time to symptomatic relapse. It is possible that the lower adherence in the low red meat group could have contributed to this. And although some of the previous studies we discussed makes it seem clear-cut, I feel like there's a lot we do not understand about dysbiosis and IBD and how diet contributes to this. Now, moving on from IBD, the next thing we're going to be talking about is eosinophilic esophagitis. So eosinophilic esophagitis is a allergic inflammation of the esophagus. It's a chronic disease. It can be treated with medications and it can be treated with diets. And diet is frequently offered as a first-line option for both adult and pediatric EOE. An exclusive elemental formula is thought to be effective, and we will go through those exact numbers of how effective it is in a few minutes. But adherence is definitely a concern because this means that the child is on an exclusive elemental formula for their diet. There is a high rate of false positives and false negatives for IgE-based testing. So sometimes we may send a patient to an allergist for IgE-based testing, but most of the times, or often, this IgE-based testing does not correspond to the allergen which has caused the EOE in that particular child. So frequently what we resort to is an empiric elimination of foods. And we do that with something that we call as a 6-food elimination diet, in which we restrict wheat, egg, milk, soy, peanuts and tree nuts, and seafood. And as you can imagine, this is quite a difficult diet for children to follow. And so sometimes we might eliminate 4 foods or 2 foods to make this a little bit easier on the child. But if we were to eliminate an entire 6 food, those entire 6 foods in a child, the overall response rate is thought to be 60 to 70%. At endoscopy, which is required to reassess EOE, the biopsies are important and allow us to identify the accumulation of those eosinophils in the submucosa. A cutoff rate of 15 is frequently used to make a diagnosis of EOE, and to frequently call the mucosa in remission, we would have to see eosinophils less than 15 on repeat endoscopic assessment. There are other histological signs of activity that we look for when we look at the slides under the microscope. So it's not just the number of the eosinophils, but also the activity of the eosinophils that help in making this diagnosis. Unfortunately, when we put a patient on an elimination diet, it does result in a lot of repeated endoscopic assessment to make sure that the mucosa is in remission. And like I mentioned previously, sometimes we might modify that elimination diet for a child to go with a 2-food or a 4-food, knowing that at the time of reassessment, if activity is still present and there's still ongoing inflammation, we might need to modify that diet and restrict further. Now, this is from an adult paper, which outlines how an elimination diet can be applied and evaluated. So usually when we make any change in AOE, whether it's a medication change or a diet change, we wait for at least 8 weeks before the mucosa can be reassessed with an endoscopy. Here, the authors started with a 6-food elimination diet and after repeating the endoscopy, if a patient is considered to be a responder, which means that the inflammation is now under control, then these authors suggest reintroducing wheat and rescoping in 8 weeks. If the mucosa remains non-inflamed, then they recommend continuing reintroducing a food one by one until the offending food or group of foods is identified, and that can be forever eliminated from that patient's diet. Now, as you can imagine, this does require a lot of repeated assessments, and these patients are in the OR or the pediatric sedation suite quite frequently to have repeat assessments done. Now, this is a systematic review looking at some adult and pediatric studies looking at the efficacy of the 6-food elimination diets in inducing histologic remission, defined again as less than 15 eosinophils per high power field on the microscope. And this study showed that the 6-food elimination diet is effective at inducing remission. And this was, again, a systematic review which looked at 7 studies, 4 pediatric, 3 adult, and they found that the overall efficacy was 72.1%. And interestingly, this seemed to be consistent in both pediatric and adult studies. And this is a comparison table which showed us the remission rates among other diets which are also tried for EOE. And of note here, the elemental diet, the overall effect was thought to be closer to 90%, 94% in adults, and the 6-food elimination diet not far behind at 72%. This was a systematic review again out of Milwaukee where I trained, where they looked at patients with IgE-mediated food allergies. Again, a different concept from EOE, but similar because these patients are also on multiple restrictive diets. And they looked for the nutritional adequacy of these children who are on these diets. They looked at 890 records, and they finally found 4 studies reviewed nutrient intake in these patients. They found that 2 of these studies showed that these patients consume more vitamin E than controls, and there was a significant more vitamin E. 1 study reported that these children consume more vitamin A, and children who had multiple food allergies who did not receive nutrition counseling were more likely to have inadequate calcium and vitamin D intake. And also children with a milk allergy, not surprisingly, were more likely to consume inadequate calcium. There was 1 study that this review reported where there was adequate protein intake in a child who was on an amino acid-based formula. And there was 1 report of a possible essential fatty acid deficiency. Now, we've talked about repeat assessment and how that's so important in EOE. And I just wanted to include this briefly because this could be something that might become less of an issue over time. And this is the transnasal endoscopy. This is a procedure which is done with a small scope, smaller than our typical endoscope, which is put down the nose. And the child can be, this can be done without the child being sedated. It is safe and well tolerated. It's supposed to be lower cost, and it is becoming more available nationally. And as you can see, we are able to actually image the inside lining of the esophagus as well as obtain biopsies, which seem to be quite comparable to our standard biopsies. So this could be something that is more readily available for children in the near future and might make that repeat endoscopic assessment less of a downside to an elimination diet. Moving on to the next topic, which is the gluten-free diet and celiac disease and non-celiac gluten sensitivity or wheat sensitivity. So celiac disease, as we all know, is an autoimmune-mediated enteropathy triggered by gluten ingestion in genetically predisposed individuals. The worldwide prevalence of this is around 1%. And it's important to talk about this other concept of non-celiac gluten sensitivity or wheat sensitivity, and that those terms are kind of used interchangeably because frequently we find patients who are on a gluten-free diet for non-celiac gluten sensitivity. So we'll be reviewing that in detail. Now, to differentiate the two, celiac disease, like we mentioned, is a genetic autoimmune disease, whereas the cause is not fully understood for non-celiac gluten sensitivity. Celiac disease, the prevalence estimate is around 1% of the US population. And non-celiac gluten sensitivity is thought to be 6% of the US population in adults. We diagnose celiac disease with positive serologies as well as histological findings on an endoscopy. And those are villus blunting and increased epithelial lymphocytes. And we'll go through exactly what that looks like. Whereas for the non-celiac gluten sensitivity, apart from ruling out celiac disease and ruling out a wheat allergy, there's no other diagnostic biomarker. The treatment for celiac disease is complete and lifelong avoidance of gluten, and the treatment of non-celiac gluten sensitivity is decreasing gluten intake to as far as the patient can tolerate. So these are some of the histological findings which are seen in celiac disease. So this is mucosal blunting or villus blunting that we see frequently. This is the increase in the intraepithelial lymphocytes seen on the mucosal lining of the brush border. And this is the crypt hyperplasia that can be seen in celiac disease. Now, in contrast, if we look at non-celiac gluten sensitivity, there was this article which came out recently over the past few years, which showed that in these patients, even though we don't see crypt hyperplasia and even though we don't see villus blunting, you can see increased intraepithelial lymphocytes. You see that on the left over here in this article that was published recently. There was another article which showed that individuals with a wheat sensitivity or a gluten sensitivity that was not celiac disease had increased serum levels of soluble CD14 and lipopolysaccharide binding protein, as well as antibody reactivity to bacterial LPS and flagellin. And they also had increased circulating levels of fatty acid binding protein too, which is thought to be a marker of intestinal epithelial cell damage. And these were significantly elevated in these individuals, basically telling us that there could be some low level inflammation which is going on in these patients that we had not known existed until more recently. And so there are multiple proposed mechanisms for why non-celiac gluten sensitivity occurs. The exact mechanism is not known, but there are some theories which pertain to increased intestinal permeability secondary to a mucosal reaction to gluten, leading to stimulation of the enteric nervous system. There are some studies which suggest an adaptive immune response as these patients sometimes can have increase in anti-gliadin antibodies. It should be noted that several studies have also shown no increase in anti-gliadin antibodies, so definitely there's some mixed evidence there. And lastly, some researchers suggest that maybe there's some innate immune response that leads to non-celiac gluten sensitivity, such as a increase in toll-like receptor expression in these patients. Certainly, the patients could also be reacting to some other component of wheat. It does not necessarily have to be gluten. So I feel like we don't really have a clear understanding of exactly why this happens, but these are some of the mechanisms that people have suggested. Now, this is the classical way of making that diagnosis of non-celiac gluten sensitivity. Now, as we mentioned previously, there are no reliable laboratory markers for non-celiac gluten sensitivity, but wheat allergy and celiac disease must be ruled out. And once that is done, the patient is put on at least 6 weeks of a gluten-containing diet, and then 6 weeks of a gluten-free diet after instruction from a dietitian, followed by controlled reintroduction of gluten versus placebo, followed by a 1-week gluten-free diet washout, followed by a 1 week of crossover. And symptoms are assessed at every stage, and this is the classical Salerno diagnostic criteria. Now, obviously, this is not something which is very feasible in the clinical setting. This is definitely doable in the research setting, but it's definitely not practical for a clinical setting. This is like a schematic picture of what that would look like and what was initially followed for the Salerno paper. And the boxes of E that you see here are basically different levels of assessment via questionnaires to reassess symptoms. Now, we have found, and I think a lot of people can probably say this, that we have a lot of people who are on gluten-free diet and they may or may not have celiac disease, but they are on a gluten-free diet for this diagnosis of non-celiac gluten sensitivity. And this trend is confirmed by NHANES database. So NHANES is this national survey which actually represents the US civilian population because of its multi-stage stratified approach of survey. And at least 5,000 people per year are surveyed for this. And this study showed that there was an increase in the total number of people on a gluten-free diet over time. And this has increased in surveys done in serial years between 2009 to 10, 2011 to 12, and 2013 to 14. And that was a significant increase, as well as there was an increase in the number of people who are labeled as PWAGs, and those are persons without celiac disease on a gluten-free diet. And that number has also been significantly increasing over the years. This is another form of the same statistic, which shows that the total people without celiac disease avoiding gluten, who then that number seems to be significantly going up over the years. And more interestingly, that number is also increasing among children. You'll see at the bottom, children between age to 6 to 19 years have had an increasing prevalence of people who are avoiding gluten in this age group as well. Now, why is this a problem? This was a study which came out from a celiac disease clinic and found that people who present to this clinic, most of the times, 87% of them are already on a gluten-free diet. And so they come to the clinic to evaluate for celiac disease, but they're already on a gluten-free diet. And the mean or median length of time that these people were on a gluten-free diet was 2.3 years. Now, we do know that a patient needs to be exposed to gluten on a regular basis in order for the serologic markers and the histology findings to be more accurate to diagnose celiac disease. And if a patient is already on a gluten-free diet for 2.5 years, it's going to be very difficult for them to start reintroducing gluten into their diet. And there's definitely going to be some reluctance to do that. Another study which was interesting was the diagnosis of non-celiac gluten sensitivity in children. And this is a paper that tried to look at exactly what that number is, because we believe that it might be different from the prevalence in adults. So this was an Italian multi-center double-blinded prospective gluten challenge crossover study. And the goals of the study were to look for symptoms of IBS and see how many of these children with IBS would actually have gluten sensitivity or non-celiac gluten sensitivity. So this study looked at different scales. There was a VAS scale, which was the visual analog scale. There was the IBS severity score. And there was also the SDAIC, which is the State Trait Anxiety Index for children. And they looked at the different scores in different phases of this trial. They had a run-in phase, and then they had a GFD open phase where the child was on a gluten-free diet. And then they had a phase 3 where the child would cross over either to the gluten challenge. So gluten would be introduced into the child's diet without them knowing, so it was blinded. And also the placebo, where they would also have an additive into their gluten-free diet, but it was placebo and it did not contain gluten. So technically they were on a gluten-free diet at that point. So this study showed that in the GFD open phase, there was a significant drop in scores. So you can see that in phase 1 run-in, the global VAS changed from 6.1 to 2.7. However, when we look at the phase 3, whether they had gluten or did not have gluten, the 3.5 and 3.9 are quite similar. And that statistic held through with the other two scores as well. The scores dropped when they knew they were on a gluten-free diet, but when they did not know they were on a gluten-free diet, their scores were equivalent to when they were eating gluten. Now, this suggests that maybe there is a placebo effect from being on a gluten-free diet in some of these children. These authors also found, however, from 4 children who truly had a decrease in symptoms when they were on a gluten-free diet and had a worsening in symptoms when they were on a gluten-containing diet. But there were only 4 children when compared to the total of 28. The authors concluded that non-celiac gluten sensitivity exists, but likely at a lower rate than what we see in adults. So they estimated 0.3 to 0.9% of children referred for abdominal pain or irritable bowel syndrome might have a true diagnosis of non-celiac gluten sensitivity. And the authors also suggest that a double-blind placebo-controlled gluten challenge is mandatory for diagnosis, because this trial or this challenge ruled out more than 60% of self-reported non-celiac gluten sensitivity, at least in pediatrics. Now, why do we care about this? So if a child is on a gluten-free diet, is that a big deal? And studies have shown that yes, there are some nutritional inadequacies which are introduced by being on a gluten-free diet. And so we know by looking at patients who have a diagnosis of celiac disease that this elimination really is not benign. So based on this review of studies that looked at nutritional content, they found that patients who, patients who are on celiac disease, patients who are on a gluten-free diet for celiac disease had an excess of kcal intake, simple carbohydrate intake, saturated fats, and lipids, and had deficiencies in some of these micronutrients that are mentioned here. And this was another study which came out from Italy. And again, this showed that the diet for these pediatric patients who are on a gluten-free diet is different from patients who are on a regular diet. In general, they consumed more calories. They had a higher percentage of calories from carbohydrates. They had a lower percent of calories from fat, and they had an overall higher glycemic index. There are toxicities that can be introduced by being on a gluten-free diet. Using the NHANES data, this group from the Mayo Clinic looked at all patients with celiac disease and those who are on a gluten-free diet for not having celiac disease. And they looked at blood lead, mercury, cadmium, and urine arsenic levels using a regression model that they use for adjusting for demographics and rice and seafood consumption. They found that those who were on a gluten-free diet had significantly increased blood mercury and lead levels. And they also had higher urinary arsenic levels as well. So in summary, gluten-free diet is clearly required for celiac disease, and non-celiac gluten sensitivity and wheat sensitivity exists, but it's likely not common and definitely not as common as what we see on the adult side. The pathophysiology of it is not well understood. Unfortunately, we do not have a good biomarker to reliably diagnose it. There are some nutritional risks and toxicities introduced by a gluten-free diet, and elimination should only be undertaken with the assistance of a dietitian. Coming to the next topic, which is plant-based milks. If it's not from a cow, can you still call it milk? This is the title of a 2016 NPR article, which details the years-long struggle between the dairy industry and manufacturers of non-dairy milk. Non-dairy milks have actually been around since the 13th century. Almond milk was first described in Asia in the 1200s. And despite this struggle that has happened between the cow milk industry and the non-cow milk industry, there has been a steady increase in the non-dairy milk industry, which is depicted in this picture over here. Now, there are some true indications for being on a plant-based milk or a non-cow milk. And this could be milk allergy. This could be a vegan diet or lifestyle of the family. It could be concerns for the environment. We know that cattle rearing has a significant impact on the environment. And then there are softer indications like lactose intolerance, which is truly not an indication because lactose-free cow's milk is available. Now, despite this, we have seen over the years, this is data from the USDA, which shows a gradual increase in the consumption of non-cow milk over the years and a slow but steady decline in cow's milk consumption. Now, this data is also from the USDA, and this breaks down that milk consumption among age groups and also translates the total volume into cup equivalents. And this shows that the average daily consumption in 2003-2004 was 1.07 cups of milk for a child per day. And that has steadily declined over the years to the 2017-2018 data, which is 0.79 for children and just 0.4 for teenagers. NASPGAN, or the North American Society for Peds GI, came up with this comparison paper or a review paper looking at these plant-based milks, and I highly recommend the interested person to go and take a look at this if you're interested. And this really looks at the different perspectives and compares all of these plant-based milks to cow's milk. And it's, first of all, we know that the nutritional content of these alternative milks vary greatly based on the type of milk it is, as well as what additives are placed. However, we know that cow's milk is really rich in protein, and the only two other milks which come close to this are pea protein and soy protein. We also know that cow's milk is rich in fat, and we know that protein and fat are very important for growth. And so there's a paper which I'll show you, which also speaks about growth in non-cow's milk, and the reason behind that is thought to be the nutritional differences in protein and fat among cow's milk versus non-cow's milk. Now, this is also taken from this review, but it quotes a Spanish paper which shows 30 cases of nutritional disease in patients who were on an exclusive non-cow milk-based diet. Now, the downfall of this paper is that it doesn't really state exactly what other diet each patient was consuming. And so it's really unclear amount of beverage consumed and whether these children were on an age-appropriate diet otherwise. But this Spanish paper showed slow linear growth, poor weight gain, and some occurrences of vitamin deficiencies, vitamin A, vitamin D, scurvy, as well as iron deficiency anemia in patients who are on an exclusive non-cow milk-based diet. Now, there are some other risks that have been put forth. Almond milk is associated with hyperoxaluria. At least there's a case reports of that, and that has caused hematuria and kidney stones. Almond and soy milk are associated with dental caries, but that is based on the amount of sugar content that is added to these milks. And this review suggests that problems only arise when the volume of milk intake exceeds the usual recommendations for milk intake for that particular age. Now, there was this paper which came out from Canada, which is very interesting. They studied 4146 children who aged 24 to 72 months, and it was a cross-sectional study. And this study showed a dose-dependent association, which meant that each cup of non-cow milk that was drunk was associated with a 0.4 centimeter of lower height. And they postulated that this is likely due to a presence of animal-derived IGF-1, which is present in cow's milk. And they stated that at age 3 years, in a child who was age 3 years and consumed 3 cups of non-cow milk per day, they were on average 1.2 centimeters shorter. Now, it was a cross-sectional study, so we don't really know if these effects persist, if they correct, or if they worsen over time. And also, the paternal height was not taken into consideration, so we weren't sure exactly if there were other confounding variables that could have affected the results of the study, but this is interesting for us to go through. In summary, plant-based beverages are certainly not milks. There are key differences in macro and micronutrients, and also wide variation in these plant-based beverages, which can lead to significant risk from a nutritional inadequacy standpoint, particularly in a child who's consuming a large portion of these milks per day and not consuming a regular diet otherwise. However, some fortified plant-based beverages may be safe, especially when supplementing a balanced diet, and clearly plant-based beverages are needed in certain settings. Now we're going to move on to a low Fodmaps diet. So the low Fodmap is basically a diet which is low in these Fodmap foods. And a Fodmap is a fermentable oligosaccharide or disaccharide, monosaccharide, and polyols. And so the low Fodmap diet is a diet that removes these slowly absorbed or indigestible carbohydrates from the diet. And it is frequently prescribed for irritable bowel syndrome. Irritable bowel syndrome, based on the Rome criteria for functional gastrointestinal disorders, is diagnosed based on the set of strict criteria. And in general, if a child has chronic abdominal pain that is related to a change in frequency or form of stool, this suggests a diagnosis of IBS, particularly if the pain does not resolve with resolution of constipation. There are up to 40 grams of undigested carbohydrates enter the colon every day. And some of these are in absorbed forms, and forms that can be eliminated without any complications. And sometimes there is bacterial fermentation of certain compounds or these Fodmap foods, and that produces gas and fluid distension of the colon. And that is thought to produce symptoms in a patient with IBS. Now, this is a study from Bruno Ciumpatazi's group down in Texas Children's, and this is a prospective cohort study which looked at 8 patients with irritable bowel syndrome. And there was a baseline period of 7 days and then 7 days of a low Fodmap diet. There was pain and stool diary assessment of these patients, and this study showed a decrease in the frequency in the mean weekly abdominal pain level, the highest weekly pain severity rating, as well as the number of abdominal pain episodes interfering with activity when a patient was put on a low Fodmap diet. This group went on to conduct a randomized double-blinded controlled trial looking at 33 pediatric IBS patients, and they had a baseline period of 7 days, and then they were randomized to either a low Fodmap diet group or something that they referred to as a typical American childhood diet for 48 hours, followed by a 5-day washout period, and then a crossover to the other group. And in this study, again, pain and stool diaries were assessed for these patients frequently during every phase of the trial. And this is actually a negative study. They showed that there was a decrease in the mean abdominal pain severity, as well as a change in the total GI symptom score, which was not significant in either diet. So it didn't depend on which diet the patient was randomized to, but there was no significant decrease, or there was an equal significant decrease in both. This was another study which was done by the same group. Again, it was a randomized double-blind controlled trial looking at 23 pediatric irritable bowel syndrome patients. They had a baseline period of 7 days, and then they were started on a low Fodmap diet, then randomized to include fructan or a placebo for 72 hours. And then a 10-day washout on a normal diet, and then crossover to the other group. And here too, pain and stool diaries were assessed, and they found that the frequency of abdominal pain actually decreased when they were not getting fructan, so they were just getting placebo, and it increased when they were on getting fructan, suggesting that maybe fructan is what is exacerbating symptoms in children with irritable bowel syndrome. Now, if you look up a low FODMAP diet, there's a lot that you can find on the internet. These are some of the foods which are eliminated and some of the foods that are suitable for a diet. The classical way in which this diet is implemented is a phase 1 elimination for 2 to 6 weeks, followed by phase 2 of reintroduction and a phase 3 of personalization. So the reintroduction is done one food at a time or one group at a time, and symptoms are observed for. And if the child or the family identifies the food which is causing symptoms, then that food is permanently eliminated from the diet, and that comes to the phase 3 of personalization. Now, it's a complex diet. It can be difficult to implement. Online info can be confusing, overwhelming, and may not suggest appropriate replacements for these restricted foods. And so this is where we really depend on our dietitian for it to really implement this diet and suggest good alternatives. Another good resource is the Monash University, which actually formed this diet. So this is another great resource for patients and families to help in navigating this diet. There was a study which looked at the nutritional adequacy of this diet in children with IBS, and the authors concluded that children with IBS on a low FODMAP diet had a decrease in kilocalorie and calories and carbohydrates consumed, and there were small changes in the micronutrient consumption between a regular diet and a low FODMAP diet. So in summary, there is limited evidence with short trials and small numbers for children with IBS and a low FODMAP diet. And attention is required to ensure that there is nutritional adequacy during the period of restriction and also the period of reintroduction. And specifically in that phase where the child personalizes their diet and forever avoids a food, we have to make sure that there are good nutritional alternatives for that food that is being avoided. And that brings us to the end of our talk. We have discussed nutrition in IBD and EOE and celiac disease and non-celiac gluten sensitivity and also irritable bowel syndrome. And in conclusion, there is increasing evidence for diet therapy in the treatment of pediatric gastrointestinal disease. And there's also an increasing desire for families to pursue these options over medications. Implementation of a diet can be challenging and may introduce deficiencies and toxicities. And families should be counseled on the evidence supporting a certain diet therapy, or rather maybe the lack of evidence supporting that diet therapy, and meet with a registered dietitian before starting that particular diet. And thank you very much.
Thank you so much. Please feel free, everyone, to put questions either in the chat, or you can use the Q&A function. I was just struck thinking about my own eating habits, which are sometimes good and sometimes not as good as I would like them to be. It's really hard to ask families to eat whole foods that are not processed or packaged or containing any of these additives, and it can be quite expensive. So I just wonder if people ever talk about, the idea of food as a prescription, right? Could we have it packaged and delivered to someone just like a bottle of pills is? Here's your medicine for the week, but it's actually a box of fruit and some vegetables and lean meats. Is that concept get talked about, how to make it easier for people to be making these dietary choices?
Yeah, I think that's a hard question, Emily. So studies have shown that gluten-free diet is actually more expensive than a regular gluten-containing diet. And so that has been well described. And also when cost is a prohibitive factor, diet becomes less diverse. And we know that they'd rather just eat the prepackaged, ready to eat gluten-free foods rather than eat, make good, healthy fruit and vegetable choices. Now, there's a slide which I took out, but it talks about the Medical Nutrition Equity Act, which is a act which is currently introduced in the Senate and the House of Representatives, which basically is an insurance mandate to allow insurance to cover some of these prescribed foods. And it really is more applicable for patients who require formula for treatment of a disease. So the exclusive enteral nutrition diet and the CDED partial enteral nutrition diet, or even the elemental formula for EOE, these are prescribed diets and prescribed treatments. And the problem is that sometimes insurance companies don't see these as treatments and see them as just diet, lifestyle modifications, when that truly is not the case. So unfortunately, no, there is no prepackaged treatment form of these type of diet therapies, but hopefully soon.
Yeah, I mean, I was just really struck by the inflammatory bowel disease data in particular. I mean, it's like if you could choose between formula and whole foods versus taking steroids, probably better to eat good food. What do you say to patients about alternative milks? I can share what I say because I talk about them a lot.
Yeah, I think, I tell them about the protein differences, the fat differences. Now I'll probably start talking a little bit about more the height differences that has been pulled up by the Canadian study. But I think ultimately it is a personal decision, and we kind of support the family. We always try to support the family through their decision, and making sure that they are choosing an appropriate alternative is, what I tend to focus on with my family. So I do recommend pea protein milk at times because it is good in protein. But yeah, I think, sometimes it makes sense to have them meet with their dietitian and to really look at their diet to see where it's lacking and suggest the appropriate alternative, even if they go with something like almond milk or something, suggesting a way to supplement some of the shortcomings from that diet.
Yeah, my sort of glib, the general pediatrician's view, I usually say something like, it makes me feel like an unloyal Wisconsin person, but I have to tell you, you don't have to drink cow's milk. It's a convenient beverage that has good protein and fat and vitamin D and calcium. So if you're choosing other milks, you need to make sure that they have those things in it. And it's expensive to do the other milks. So I think I talk to families about cost and really like not all alternative milks are equal. So I think that's the big point to take away, that they really need to look at the content. Yeah, that height study is a little tricky because if you don't know the parents' heights, I don't know how you can draw any conclusions from that really. And it's like this much. So I don't know if that's like clinically meaningful for anyone. Sue Berry just put in the chat that she thinks we should all be advocating by writing to our Congress people about the Medical Nutrition Equity Act. I agree, Sue. We would love to advocate about that. So maybe we can have you send something out to the whole faculty listserv, because that sounds like a really important way for us to advocate for patients, because medical formulas and medical foods are very expensive, that's for sure.
And another quick blurb about that Medical Nutrition Equity Act. They have a section on their website, which is the Patients and Providers for Medical Nutrition Equity is the name of their website. And they have a section where we can actually report stories, or the families can report stories where they were prescribed a certain food or diet, either for metabolic disease or for gastrointestinal disease, but it was not covered by insurance. And the more stories we have, the better. And so I would highly recommend either people who are interested or families who might be going through this to visit that website.
Great, thank you. Tell us more about the magical virtual reality nasal endoscopy. Like, do we have that? Will we have that? Is it very expensive? How do you learn how to do it?
It's exciting. It's definitely exciting. So the virtual reality is basically distraction. And so we are distracting the child while we put this endoscope down the nose and into the esophagus. And we don't have it here, but it is becoming increasingly available in other places. I don't know exactly what the costs are, but the results are definitely quite equivalent when you compare it to standard endoscopy. And some of these patients are in and out of the sedation suite so often that it just makes sense for these patients. And I feel like in a matter of time, they might be looking elsewhere in places who do have this type of facility to have their EOE care, because nobody, likes being put under anesthesia. Certainly it's safe, but nobody likes that if you can do it without.
So the virtual reality is for the kid?
Yes, that's right.
Oh, I didn't understand that when you were talking about it. So they put on the goggles and they're like looking around being distracted, and then you slip the thing down their nose.
Right.
Oh, very cool. I guess I just would be curious to hear your practical experience with Fodmap diet for IBS. It's so challenging. And if you were going to recommend a limited version of that, what would it look like?
Yeah. So sometimes we see patients who have been on a low Fodmap diet for, forever. And that's not necessarily how it was designed. And I feel like the first thing with low Fodmap diet is to ensure that we have a plan to reintroduce it. And so it is a highly restrictive diet, but it should be initiated with a plan to eventually reintroduce these foods. I think irritable bowel syndrome itself is a challenging diagnosis because frequently these children have constipation, and the guidelines really say that the constipation should be treated and there should be no resolution of symptoms or no resolution of pain before you make that diagnosis of irritable bowel syndrome. And so the first challenge when you see a patient like this is to, question, do you have the right diagnosis? Does constipation still need to be treated before we make that diagnosis of IBS? And then the second challenge is coming up with a good plan about that diet, making sure they get the appropriate teaching from a dietitian and have an appropriate plan to reintroduce these foods. Yeah.
Great. Just looking to see if we've got anything else coming in the chat. I've got maybe one or two more questions, but just please, everyone, we've not been getting the greatest response rate on our evaluations, and it's super helpful for our speakers to have proof that they gave an excellent grand rounds and for us to continue to evaluate our session. So please look in the chat and click on that link to evaluate today's session. Yeah, I guess just would, as you think about this is sort of your chance to help your referring base. When you think about people, general pediatricians send to you with dietary questions, what are like 2 or 3 sort of pearls you would want us to be putting into place in our day-to-day practice?
Yeah, that's a great question. I would say the first thing is don't put a child on a gluten-free diet unless you're sure that this child does not have celiac disease, because it makes it so much more difficult to diagnose celiac disease, or to put the patient on a gluten-containing diet to make that diagnosis. Actually, that would be one thing for sure that I recommend. The second thing that I feel like is would be a good piece of advice is to really consider the evidence behind elimination diets and to set a good endpoint in mind. So I see sometimes patients who are put on certain elimination diets without any clear endpoint, without seeing a dietitian, and without having an appropriate replacement for the food they are eliminating. So to definitely be mindful of that would be my second piece of advice.
Great. It seems like if we're really getting into significant elimination dietary recommendations, that partnering with our GI colleagues is probably a good way to go, because you have probably a lot more experience managing those things. Are there settings where just a general pediatrician and a nutritionist managing that seems appropriate?
I think yes, but it also depends on the indication, right?
Yeah.
So I think if this is like a milk intolerance, like a milk allergy, or like an irritable bowel syndrome, I think it's definitely appropriate to initiate some of these elimination diets, as long as we're going through the correct steps to make that diagnosis. And again, like you mentioned, with dietitian support and also with a clear endpoint in mind, and so that it's not an indefinite elimination without further evaluation, and that is a more like time-bound restriction or time-bound elimination with a plan to send them our way if you feel like symptoms are ongoing.
I'm just going to follow up on the gluten thing, because I think that is the biggest thing we can do to help you.
Yeah.
How long do they need to be eating gluten-containing foods for it to be appropriate for us to get the blood tests and feel like we might catch signs of it if it were there?
Yeah, there was a paper which I did not review for this talk, but the paper suggested the equivalent of 2 slices of bread for a period of 8 to 12 weeks is sufficient exposure to gluten before you, 2 slices of bread per day for 8 to 12 weeks before you can rely on those serologies and histology findings. So, and that's challenging, obviously, in a patient who is symptomatic, maybe with non-celiac gluten sensitivity or irritable bowel syndrome, where they've already restricted gluten and they're feeling better, and then they see you in clinic and you're asking them to start eating bread every day, which definitely is challenging. But yeah, that is, from what I recall, the recommendation.
Okay, great, thank you. Well, wonderful. Thank you so much. There's lots to think about there. And I think counseling about food and nutrition is a huge part of general pediatric practice, but the expertise that our GI colleagues bring is so helpful. So thank you so much for a great talk. I hope everyone has a great Wednesday.